Thanks. What we just want to turn our attention to here is the big question of, given all of that, the state of the science, the shape of the question, the shape of the challenge, what are the opportunities and challenges now standing out in the Canadian environment? Keeping in mind that along with all of the depth of information today, we're trying to grapple with the question of, if there is a major assessment on dementia for CAHS, what are some of the things we should be covering? So starting to sort of think about that question, I'm going to ask first the panel to comment on this question briefly. That's the rapid fire part of what opportunities and challenges are standing out, and then we'll open it up to the group. So maybe we can start down with Howard Chirkow.
I think this is a great question. The opportunity is clearly that, as Subi Banerjee pointed out, that if you're an optimist, we're at the beginning of a time when dementia is recognized to be a global problem. The motivation is there, the energy is there in terms of the public and the politicians to do something. So this is a tremendous opportunity for the community and the academic community to take leadership in suggesting what should be done. The challenge is twofold. One is that we have to always in Canada be conscious of, we don't want to be a me too. We don't want to do a finger to or an ADNI to. There are major studies that have already been started in the US and in Europe, and their leadership has been shown in organizing dementia research many years ago. So we're sort of late coming to the game. We have to turn that into the opportunity to organize ourselves using cutting-edge technology and cutting-edge diagnostic approaches and turn that into an advantage. But it leaves us the challenge of finding the funds. The cost of dementia in Canada is $50 million a day. And I remember a few years ago, Pat McGeer lobbying the government saying we should at least have the cost of dementia for one day should be used every year for funding research on dementia in Canada. So the problem, and it's a problem we don't only have here in the States and in Europe, is recognizing the magnitude of the problem and generating a sufficient support from the government to mount a real meaningful approach. One thing that Mia may not have pointed out was the high cost of doing long-term prevention studies, which are going to have an impact. And if we're going to make an impact worldwide, we are going to have to galvanize our government to understand that we should have started 20 years ago in doing these prevention studies. If we're going to impact on the disease 20 years from now, we have to find the funds and the support and the energy right now to get into the game.
Thank you. Mia?
Okay, I can just continue that. Of course, from my point of view, the prevention is one area that is still quite easy. The timing is good. And finger is, for me, more the starting point. So there is still so much more what can be done for the different target groups, what can be done using new technology and things like that. So I think that is really a play yard where you can do a lot. And as said, the targeted interventions for how you can tailor the interventions there is interesting. What I'm also thinking from Canada, you have so lovely cohorts. There is strong research for stroke and other diseases. Can you find also links there together that Alzheimer is not in isolation? Integrated interventions could be also something. And the third point what I had, I was mainly now talking about lifestyle prevention, but the prevention is also, we can also use drugs. And it's also, we are just now starting to use the combination, combining lifestyle and drugs. And here is an area that is not yet, we have not been doing so much there. So that's a few points for me.
So moving on from the prevention to the treatment side of things. Treatment isn't just drugs. And in Alzheimer's disease, at the moment, treatment, there aren't many drugs that we can use. Treatment isn't just drugs. There's a fantastic amount that is already being done all over the country in small areas, fantastic innovation and fantastically good quality services that are being provided to people with dementia. The opportunity and the challenge is that you'll find this as a lottery. There's no consistency in the way that care is provided. You may find an absolutely brilliant end-of-life pathway in some area, a fantastic antipsychotic drug program in a totally different place, and somewhere that's brilliant at diagnosing in another. So the challenge there is to decide as a group, and again, this group may be very well placed to do that, what good looks like, to discover those kind of burning lights out there in terms of great services doing great work, to be able to discover those, and then to be able to deliver those at scale, and to be able to deliver them kind of nationwide, rather than just by the chance of where you go. And I know there are particular challenges because Canada's so big and how you do it in rural areas or whatever. But, there's already fantastic things going on. If you can identify them, and they're things that are authentically Canadian, that work in your systems, if you can identify them and then deliver those already, then you'll go a long way to improving people's quality of life. But what that requires, again, is this agreement about what good looks like, an agreement that there are kind of minimum things that services should do. That's diagnostic services, that's treatment services, and it's also care services. So I don't think that, I think the thing that is missing to an extent in a strategy that just looks at prevention and research, important as those things are that there are many, many millions of people who will develop dementia over the next 10 years for whom the prevention and the research may come too late. And we need to focus on those people as well. We need to deliver improvements now, and we can learn from what we already do.
Thank you.
So I'm going to echo the same theme. Eve told us about a Canadian strategy that includes research and prevention. No care mentioned inside of the viewpoint. That's unconscionable, right? So the strength of what has been done in the countries with the national plan is that they understand that care is at the heart. It's the centerpiece of what we're trying to do. And without care, I don't think we really have a conscionable national plan. And part of what I hope our discussions today will be to underscore that, because it is critical. And I think Subi's presentation outlined the value of systems of care in the UK, and certainly when Prime Minister Cameron talks about it, it's integral. So that's important. Number two is speed. I think there's a sense of urgency. This is a very unique problem because we see the tsunami of the demographics shifting. Every speaker this morning showed the bump ups that we're expecting. And I would ask the question, are we moving at the right speed to meet the challenge? And are we investing at the right pace to meet the challenge? Or are we doing our business in the usual way where we will plod along and not actually take the unique window of opportunity and capitalize on it? So I think we have to appreciate that timing is critical here, and we've got to step our game and our speed up. And the final thing is we have to be prepared to take things up into regular care. So Mia starts talking about an effective strategy and evidence of prevention. How much evidence does one need before one begins to think about an implementation plan? We could be doing prevention studies in 30 years from now saying, well, we just have to do one more. And I would see a potential for a huge gap if we don't actually get some of this into hands today, particularly given the low risk of side effects and, the safety with which this program can be done. So I think we have to balance some of the research imperatives with the need to get things into the public at the present time.
Okay, thank you to the panel. We have time for 2 or 3 questions. Randy has the mic and he'll toss them out.
Pat Armstrong, York University. Several of you have mentioned that women, are twice as likely to be diagnosed with Alzheimer's. We've heard that they're much more likely to be the unpaid care providers, and I would add of the paid providers as well. So how does gender get included, and what are the significant research questions we should be asking beyond just getting how many there are?
Great question. Who would like to take that one?
Howard. Well, there's a viewpoint from CCNA, and Mia probably wants to offer a comment.
The role of the caregiver is hugely important, and there are many research questions around caregiving, but what we've decided to focus on is trying to get something very practical, which is, can we show that an intensive caregiver support program focused on caregivers who are still in the workforce can have an impact in keeping those caregivers in the workforce. Because one of the problems in caregiving is proving that something works, because there are all sorts of different approaches to supporting caregivers. Can we develop a program, and one has been developed by Joel Sadavoy in Toronto that we like very much. Can we show that it works? Can we show it has an economic impact? And can we show it has enough of an impact that governments may then take it on and say, this makes sense. If we can provide this sort of caregiver support program nationally, we can prevent this many thousands of individuals from leaving the workforce to look after their parents. So this is the approach that we've decided to, a very practical approach. I just want to make one last comment about challenges. That one of our challenges in Canada in developing research is a very typical Canadian one, which is that we are having a national research program, but there are some excellent provincial research programs also underway. Andre, under Michael Strong in Ontario, is very well developed and underway, and there's CIMA-Q, a program looking at Alzheimer's in Quebec, and there's an Alberta program coming online. So in order to really make the best use of our national research dollars, we have to harmonize and work with a federal and national research organizations working with the provincial programs as well to get the most bang for the buck. And this is another very Canadian challenge.
Okay. Rapid fire.
Yes, I can just quickly add for the gender issue from the research perspective. The question has been why women have higher risk for Alzheimer's disease. One obvious one is that women live longer, but that seems not to be the whole story. There is something else as well. One strong hypothesis has been the hormonal issue, the drop of estrogen level after the menopause, but that's not clear. There have been no evidence from the randomized trials supporting that helps. Are there other issues? Psychosocial factors, stress, depression, dietary issues, we do not know. And I think that's the important issue to study further. And the other one is the effect of the intervention different between men and women? That's something we want to study in the finger. I think that should be studied more generally in all trials, what we are doing.
Okay, next question, please.
Paul Armstrong, University of Alberta. Thanks for a stimulating start to the morning. As a non-expert reflecting on the recalcitrance of this problem, I would be interested in knowing whether the panel is unified in their taxonomy of this disorder they call dementia, or whether in fact one of the challenges is that we don't understand what it is that we're studying. So that would be the first question. The second would be sometimes there's a clue to that from, for example, as might be explored in the finger study relative to subsets and the heterogeneity associated with this disorder, because clearly an assessment that the Academy would want to consider here would want a clear question, and taxonomy might inform that.
So great question, thank you. Taxonomy is interesting. It's what you think you know and then what you actually know. I think it would be fair to say that as we've gone along, things that we trusted to be true don't look so true anymore, and what's old is new. So it used to be that we divided, when as a medical student, we divided presenile and senile forms of disease. It strikes me that we may be coming back to that in the sense that there are genetic forms of Alzheimer's disease, genetic forms of frontotemporal dementia and ALS. They're genetic determinants where monogenic inheritance leads to the disease. So that seems like a grouping that will hold up. Where things are getting more complicated is late life dementia. Alzheimer's disease tends to occur with comorbid pathologies, at least 30 to 40% of the time. What do we call it? We call it Alzheimer's disease, but there's vascular comorbidity, there's Lewy body comorbidity, there's other pathologies in the brain. We're still calling it Alzheimer's disease. I noted that Subi tended to use the overarching term dementia. I tend not to use that word dementia because it's just a descriptor. It's not an etiology, and as a neurologist, I'm trained to describe etiologies.
So one quick response so that we have time for one more question. Yes.
I think that taxonomy is very important. I think that understanding the heterogeneity that exists in dementia is tremendously important. Dementia, as you say, is not a diagnosis. It's a syndrome with it, which is caused by a number of illnesses, and we need to act at both levels. There are things that are shared, however, by all people that have dementia in terms of the progressive degeneration, and that's really important that's why national strategy can be focused at dementia, whereas specific treatments may well be focused at Alzheimer's disease of a particular sort. I think the last thing about words and talking about terms is that we have to be very careful that we don't have a flight into discussion about terminology in an excuse not to actually do stuff about the real illnesses that are out there. There's no doubt that dementia is a profoundly negative experience for many that have it. And there's no doubt that there's an immense amount that we could be doing that we're not doing for those people. So yeah, we need to know more, but we also need to act now.
Okay, one quick question.
Thank you. It's David Chang from Western University. Again, I echo thank you for the panel for a wonderful discussion regarding prevention, intervention, and pathophysiology. My question regarding for the assessment for the academy is a huge population coming up now in the periop surgical setting. We all aware and we have evidence now demonstrating post-op increase of delirium in many, many patients, especially elderly patients. And those patients are actually very susceptible and increase the risk, not unlike the cardiovascular risk in patients evolve into dementia or Alzheimer. So I would like to ask the panel, during your investigation or intervention, have you come across that population? And is any insight in that? And also for our academy, moving into assessment, this is a major population to look at, particularly in the developing country. Last year or earlier this year in May, the WHO just ratified a resolution on surgery as an essential services to all countries. So we're going to see a big explosion of surgery around the globe.
Would like to take it. Okay, so I would offer a comment about delirium. I mean, one way to think about delirium is that it takes a vulnerable brain to begin with, and a way to understand it is to appreciate that there is a pathology vulnerability that builds up over a few decades before people manifest dementia. Delirium is acute brain failure and generally within a susceptible host. So in some ways, the more cognitive impairment there is, the more likely you will face delirium, particularly if you manage to throw in a few medications with some anticholinergic potential into the same mix. So that's a way of thinking about delirium in that context.